Well, I guess Facebook ain't happening tonight. I'll do one more thing. And here we go. Good evening, good night, good evening, good afternoon, Facebook, good afternoon, interweb. I am Dr. Andrea Vidali, standing in for Dr. Sally Sorrell, who unfortunately for personal reason is not available tonight. And I'll try to do my best, but I know I will never be as good as Sally as a moderator as well as an entertainer. Let me first start with introducing our amazing guests tonight, and they are. Let me start in alphabetical order. Dr. Maurice Chung, who is a surgeon, urogynecologist, endometriosis expert. Please, do you want to introduce yourself, Dr. Chung?
Hi, everybody. I'm glad to be back. And I'm so sorry to hear that Sally is not here because of her family issues and her mother. I am from Canton, Ohio, soon to be Cleveland Clinic Foundation Mercy Medical Center of Canton, Ohio. I'm a urogynecologist and also a MIS surgeon, and also focus on treating pelvic pain for the last 25 to 30 years. And I'm glad to be here and to join with all these respective colleagues to talk about groin pain tonight.
Let me get now to Dr. Mosbrucker, who is a nationally and internationally recognized endometriosis expert and extraordinary surgeon. She is from the West Pacific Northwest. Her website is pacificendometriosis.com. Do you want to introduce yourself, Dr. Mosbrucker? Good evening.
Sure. Hi, everybody. I'm Cindy Mosbrucker. I live in Gig Harbor, Washington, and that's where my practice is. I am also a urogynecologist and trained with David Redwine, and I've been doing endometriosis and pelvic pain for the last almost 20 years. When I met Dr. Redwine, I thought it was really cool that I could add general surgery to my urology and gynecology, because those were the three things that I always wanted to do when I was in medical school, and I had a hard time figuring out what residency to do. Tonight, you will see that I'm also part orthopod and part physical therapist, because when we talk about groin pain, it kind of brings in those specialties as well. So since we don't have a real PT, Sally, I guess I'll try to pinch hit as best as I can, but I'm honored to be here, and so happy that Sally and Dr. Vidali started the Endometriosis Summit. I have my Endometriosis Summit t-shirt on, but it's too cold to wear just a t-shirt. So
Thank you, Dr. Mosbrucker. And by the way, if you're interested about learning more about the Endometriosis Summit, www.theendometriosissummit.com. Let's not forget that over there you will find the information about our next virtual summit, which will happen in March. and tickets are available now. It will be amazing. It'll be an expanded version of this very, very short conversation that we're having. So it will be extra interesting for you, whether you are somebody who is affected by endometriosis or whether you're a practitioner in this field. And of course, Dr. Zoland, who's always been the last one to be called at school and also on Zoom calls. Dr. Mark Zoland, general surgeon from New York City, an expert in really pubic pain and hernia expert. Would you like to introduce yourself, Dr. Zoland? Good evening.
Sure, thank you. You know, again, I agree. Andrea, it's wonderful to have you, but it would have been lovely to have Sally here. I have my practice in New York, and I have a keen interest in groin and pelvic pain. I'm a general surgeon. And what I found over the years is that this area sort of bleeds into all the other areas with these other disciplines. And I think we've all found over the years, I probably can speak for all of us, that we have to learn each other's angles a little bit. And this way we can cover the gaps, because before all of this started becoming more of a cohesive construct, there were quite a few gaps. And I think we're not there yet, certainly, but we're getting better and we're covering the gaps better. And, you know, just honored to be here with you all.
Mark, I just heard that you're also either have written or you're writing a book or you're coming out with a book. Do you want to just briefly mention that?
Sure. Thank you. It's called Deciphering Groin and Pelvic Pain, and it's the goal is not to be a comprehensive book by any stretch. It's just too broad of a topic to really cover all the bases. But the purpose is to have a readable book for lay people and for medical allied professionals who are not surgeons to kind of understand the construct of groin and pelvic pain from the way we see it. Not that they can learn exactly how to do it from the way we see it, but what we're looking for when we see these patients. Because I think for me, the biggest problem was that patients weren't getting to each of us, I believe, and this was sort of a theme that we kept seeing over and over again at the conferences. They would see us as their fifth, sixth, seventh doctor. And the goal is really to get a lot of this on the front of people's minds, rather than, you know, all of us don't want to see somebody that's already had a hip replacement and yet it was due to endometriosis that they were having the pain, or an occult hernia, or, you know, a urology issue. And, you know, ultimately we all need to have cross communication with each other. And that's what the book is meant to start, that cross communication. And certainly the lay person needs to be educated as well in this area so that they know what they should be looking for. And it's the start of that, or at least I hope that's what this will do.
Okay, thank you, Dr. Zoland. I'm Andrea Vidali, and I'm the co-founder of the Endometriosis Summit, and I'm a physician and a surgeon, as well as a reproductive immunologist and reproductive endocrinologist. Tonight's topic is so broad. It's so broad, and we are dealing with pain. But the title of the topic is, it's kind of a strange title that Sally wrote: "Is your pain your ovary, groin, leg, and abdominal pain?" So it really it's sort of like a pelvic pain primer to speak of. And perhaps I'm going to ask Dr. Mosbrucker to start with perhaps like a little bit define when we're talking about growing pain or pelvic pain more generically. How would you frame the conversation, Dr. Mosbrucker?
Well, I mean, groin pain is a part of pelvic pain. Pelvic pain, to me, is kind of all-encompassing. It can be anything from endometriosis, uterine pain, diverticulitis, hip pain, hemorrhoids, bladder pain,
Ovarian
kidney
pain.
stone, ovarian pain. I mean, you name it, anything in the pelvis can cause pelvic pain. Now, in the patients that I typically see, most of it is endometriosis, uterine pain, ovarian pain, but a fair number of them have pain in their groin that is a little harder to figure out. And I started hearing women tell me that, their ovaries hurt. And then I had a patient come in and see me. I'm sorry for all the dings in my computer. I don't know if you're hearing them. I don't know how to make them stop dinging and still hear you guys. So, so I had an older lady come in once and said, if my ovary wasn't gone, I would say my ovary hurts. And I was having hip pain at the time that I was just beginning to understand was a torn labrum and hip impingement. And where she was describing her pain is exactly where I had mine. And I'm like, I don't think that's your ovary. Let's get an MRI of your hip or an x-ray. I don't remember what we did. And sure as shooting, it was her hip, and she had seriously bad arthritis and needed a hip replacement. So groin pain, to me, anytime a patient comes in and is really any age, I'm thinking, I wonder what's going on with their hip. The problem is that hip pain can be either a primary or a secondary pain, meaning that the hip itself can be causing the pain either with a torn labrum or true impingement, or they can have a functional impingement. The difference between a true impingement and a functional impingement is that the ball, if my hand is the ball and my other hand is the socket, in a true orthopedic impingement, the ball and the socket don't fit together right. And there are two types of impingement. There's a cam impingement where there's a bump of bone just above the articular surface of the femur, where when you flex your hip, that bump of bone bumps into the labral cartilage and the edge of the acetabulum. There's another kind called a pincer, which is where the acetabulum is too thick and it sticks out too much, and then it impedes the femur from flexing. And both of those will cause pain with flexion, and they can also predispose to cartilage problems where they damage the labral cartilage, which is essentially the cartilage that holds the hip in the socket. Now, functional impingement is much more common in our younger gals with endometriosis who may have unequal spasm of the pelvic floor muscles. And I think it's an unequal spasm of the left versus the right that causes the pelvis to torque. And typically it's the right side that angles forward, which means that the acetabulum, instead of being more straight up and down, is more angulated forwards, which then impedes the ability of the hip to flex. And so then you get a pseudo impingement or a functional impingement, which can be corrected by physical therapy if you can get rid of the endometriosis or whatever it is that's causing the pelvic floor to be in unequal spasm.
Dr. Chung, I guess we're starting with the hip, right? So Dr. Mosbrucker was mentioning sort of like just to put it in layman's term, that when somebody's in pain, they're sort of twisting their body either voluntarily or involuntarily in strange ways. And that ultimately results in these physiological imbalances, structural imbalances that then lead to injury, whether it's permanent or non-permanent. Do you observe this as well in your patients in the hip? We're talking about the hip right now.
Yeah, it's a hip. And see, the thing is, it's all really depends on the patient's presentation, the symptoms. And most of our patients, as a gynecologist or urogynecologist, then patient coming with pain it's down my bladder, my groin, or they have lower back pain. The question is, how do I approach that? I mean, I'm not that sophisticated to understand every little thing about the hip joint. And if it's really truly the hip pain, then of course that the physical therapy knows a lot more than I do and how to figure them out. But as a gynecologist or urogynecologist, a patient comes in whenever the age group, anywhere from the reproductive age to postmenopausal, they have pelvic pain. They will say, oh, this pain goes from my hip and down my groin. And more so, when you talk about that groin pain or the hip pain, is it unilateral? Sometimes it's unilateral, one side is worse than the other. And in part, that is very true that the neuromuscular structure, there's spasm on one and there's relaxation. And the pelvis rotated. Sometimes if you look at them, you know that they have leg length discrepancy. They usually could be a centimeter or two off. And when you examine the SI joint, you put a little heel lift under the side and you push on it, the pain actually decreases. So those are truly neuromuscular, but they have other things. So how do we approach that? You see, that's the thing. Now the hip has a branch of the pudendal nerve. I think it might be the S2. Sometimes there's a variant that goes to the hip. So, and if it's a groin pain, that we know the pudendal nerve pain, which is deep, patient perception is at the groin, at the lower abdomen, lower quadrant. So how do you distinguish whether this is a true abdominal pain or pudendal nerve pain? And sometimes the SI joint on the same side, it hurts more. So where are they coming from? The pudendal nerve, the abdominal nerve, or the SI? So that is the difficulty. And in part, the pelvis is involved, and the bulk of the problem, the bladder was involved in probably close to 85% at time. And doesn't mean that it caused from the bladder, but the bladder contribute to part of the symptom. So how do you approach that? And how do you approach the patient with lower abdominal pain, groin pain? And I actually like to hear from Dr. Zoland and with his experience. Now, is it the hernia? I do believe that hernia may, if the hernia impinge on one of those nerves, or maybe the patient have C-section, transverse, phalansteal, previous laparoscopy, appendectomy, that trap a nerve, which is the ilioinguinal or the hypogastric, or sometimes is genitofemoral. So those are the groin pain. And I have a picture here, I'm not quite sure, it may be helpful. You see this one? I'm sharing screen.
Yes, we see
Can
it.
you hear? So you see that this is all the area is the genitofemoral nerve, that's a groin pain. And here you have the inguinal pain and hypogastric. So all these nerves have neural crosstalk. Now, there was one time that I thought the patient had truly had pudendal neuralgia because it hurt so much. Her pain level was with a VAS of 10. After I gave her the unilateral pudendal block, it dropped it down to a 4. So on examining of her ilioinguinal nerve and genitofemoral, I give her a nerve block at the ilioinguinal and genitofemoral. And guess what? After the nerve block, the bladder pain went away. The pain from the ischial spine and the entire levator plate completely gone. So this is the strange thing because they have the neural crosstalk. So the thing is to identify where is the trigger and which part is the worst. And I have done neurectomy on these patients. I said, well, I can't take away your pain. I can make you numb, and they're very happy. They're numb. They're not hurting, but they're numb. So they don't have the pain anymore. They don't have the muscle spasm. So that's how I approach, because I think that I usually like to go from the bottom and up, like taking care of the bladder, find out whether the bladder is the pain generator, then go after the pudendal nerve, which is the pelvis, and move up. If they're not 100% better, I'm trying to figure out whether they have any other possibility. The SI joint, sometimes you give them a shot in the SI joint, the pain actually get a lot better. And same for the ilioinguinal or the genital femoral block. And that's my experience about the hip pain. I mean, if it's truly hip pain, and after I've done with all these, the hip pain when patient ambulate, they hurt, then I really need to get them to physical therapy and to see whether there's something going on there. But most of the referral, they're old enough, and you know that they have osteoporosis, they have kyphosis, they're gonna have some of those hip pain. But for the younger population, and I start out on the bottom, the bladder, the pelvic floor muscle, the nerve block, before I even do any laparoscopic surgery. That's my approach.
Dr. Zoland.
So I think the audience.
Dr. Chung, you want to stop sharing that, that thing? You want to get back
no,
to?
I need to get out. So I got to figure out how to get there. Okay. Exactly. Let me exit.
I think you can. Okay, there you go. We're back to normal. Okay, thank you. Go ahead, Mark. Can you expand a little bit on this conversation?
Sure. So I think what the audience is getting here is, as all of us know, that this area is wildly complicated, and you've got multiple systems going on. You've got an orthopedic system, a urologic system, gynecologic system. You've got the muscular structure. You've got the bony structure. So when you're looking at people coming in with these symptoms, all of us, I'm sure, whether it's explicitly or implicitly, have developed our algorithms to really hone down on what these diagnoses are. And as you can see, we're talking about anything from hip to bladder to gynecologic to hernias. So for me, listening to the patient is critical. Understanding exactly what their symptoms are, understanding what causes the symptoms, when they are worse, when they are better, all of these things give us clues. And geography on the human body is really important. As Dr. Chung has just said, the nerves act as a map for us. We can go by where somebody's having pain, and we can backtrack to where the dermatologic map is of these nerves. And by doing so, we can try to figure out what is impinging upon the nerves where. Is it impingement in the spine? Is it the hip that is causing some degree of pain, which is generating some nerve pain going backward towards the spine? Is it a hernia that's coming out and impinging upon any one of the nerves that we're talking about? All of these things are things that we have to think about. If we don't think about them, we're going to miss them. And it doesn't matter exactly how you arrive in your algorithm to the points that you're getting to. You just have to think of all of them and carefully rule them in or rule them out. So for me, one of the huge things is diagnostic testing. I get a very specific protocoled MRI, which for me generally looks at probably the broadest sampling of pathologies. We do very specific cuts with a very specific protocol. And oftentimes we're going to find occult hernias, we can find hip pathology, we can find bladder pathology. Obviously, an MRI is not going to show you very small bits of endometriosis within the pelvis. That has to become, come to diagnostically in other ways. But I think the algorithm has to be there for all of us. We have to, really look at the symptoms. And another huge thing for me is diagnostic nerve blocks, because if I can block a nerve and it makes the pain go away, that leads me to a potential diagnosis as to what is impinging upon that nerve. And working backward mechanically, if it's something that we can fix it. So essentially, it's about the algorithm at the end of the day.
You know, it's interesting you mentioned the diagnostic nerve blocks, because I always ask the patient, you know, I don't personally do the nerve blocks myself, but I ask the patients, if you went for a nerve block, was that like the best day you've ever had? Or was there, you know, like, you know, and it's an important question to me. And the patient says, no. Then I'm like, well, you know, maybe the nerve that was blocked was not the nerve that's affected. You know, Cindy, would you like to comment? Maybe, am I right or am I wrong? I don't know. You know, Cindy, any comments on that?
No, you're absolutely correct, because if I have a pain management doc that I work with who does nerve blocks when I suspect that they're needed. And, you know, if I ask him to do an ilioinguinal block or a genitofemoral block, and it's really the pudendal that's the problem, you know, then it's not going to fix it. And as Dr. Chung said, sometimes you can have two separate nerves that are involved, and you'll get part of it and you won't get all of it. And so it's in my view, if you get a positive result, i.e. you block a nerve and all of their pain goes away, then great, we can take that and run with it, and we have really good information. If it doesn't do anything, it could be from a number of things. It could be that the correct nerve wasn't blocked, or that the local anesthetic didn't get close enough to the nerve, that it's a technical problem, or it can be it can be that it's not really that nerve. It's not coming from a peripheral nerve at all. So for the example is that endometriosis over the bladder flap that sits less near the bladder, but more near the obturator muscle. So basically right underneath the pubic bone, can cause obturator muscle spasm, which will cause somebody to have groin pain. It can also cause spasm and compression of the obturator nerve that goes through that muscle. And so then the patient can get pain down their medial thigh, down into their the back of their knee. And then you can think, okay, they've got obturator nerve pain. Is it because of compression as it's coming out of the obturator muscle, or is it from endometriosis actually sitting up higher on top of the obturator nerve and causing that? Or is it something in the spine at the root of the obturator? So,
Dr. Chung, I'd like to take a little step back, because maybe we haven't discussed this. We should have discussed it at the beginning, but not all mechanism of pain are not all pain is the same, right? We have nociceptive pain, we have inflammatory pain, and we have neuropathic pain, and we have mixed pain. So perhaps it's worth kind of discussing about this different types of pain, because not all pains are the same, right? Not all pain comes in all different forms. You know, you got the burning. Would you like to expand on that, Dr. Chung?
Well, to try to make it simple, you have gripping pain, you have muscle spasm, you have stabbing pain. So, and then you have the menstrual pain, which is when patients have menstrual cramp. They know that. That's the menstrual cramps. They refer to that. And for pudendal nerve symptom, if it's a pudendal nerve or muscle spasm in the levator plate, pudendal nerve pain typically hurt when patients sit for a long time, and they have these stabbing pain so deep, and they just hurt. And sometimes this pain would be like a gripping or feeling somebody sticking a toothbrush in the vagina and poking at them. And that's the pudendal nerve pain. And then here go with the muscle spasm of the lower pelvis, like the ilioinguinal nerve in those area in the lower abdomen with the muscle spasm. But you know, the thing is, it's not that easy to ask the patient to differentiate their pain. They just tell me it hurts. So it's not going to help me to say.
I would argue that there's different sensations, and sometimes the patient describe it. You know, whereas like I would say that what we describe as a nociceptive pain is a pain that where there's like something somatic happening, organ distension, a contracture. Whereas inflammatory pain is usually a response to tissue injury. So, you know, which activate also those silenced nociceptors that are in the ovary. We'll talk about that. And and it's more like, whereas nerve pain is more of a burning sensation. I mean, that's a way, you know, that's what is that true or not? I mean, maybe I'm, you know.
No, nerve pain is not, because let's say, see, the thing is, I typically trying to figure out what causes the pain. Is it when she was moving around, or is it during sex or after sex, or is it when during sexual intercourse hitting certain area, it gives them a jolt? Now the bladder is the biggest organs of the pelvis, so it's doing by pain mapping. When I map the pain, when I examine them, and I always ask them, am I reproducing your pain? And I can tell you that 9 out of 10 times, the patient would tell me, well, actually more than that. If I hit the right spot, they'll tell me
only
that's
9
exact.
out of 10? Just, it's a joke.
No. Oh, well, I mean, probably 99 out of 100, but I'm just saying 9 out of 10 to be like a little bit like not to be that specific. So you touch a spot, the pain mapping will reproduce the patient's pain. Now, the pudendal nerve pain, you hit it right near the ischial spine. Patient will tell you, now that's my pain on the abdomen. And you know that sometimes that's the cause of the pain. And sometimes you hit that spot, no, that goes to my rectum. I have abdominal pain, which is right here. And then you figure that out. That's where there's a cut right there, which is the previous injury. So yes, there's something to do with the nerve pain. Some of those would tell me they have burning pain on the external genital area, like burning. Some of those, they feel like burning. Some of those like sharp. But it doesn't help me too much on that because, as you know, Dr. Zoland was saying, there's the nerve ending in the pelvis is so vast. The bladder pain referred to the muscles, and the muscle pain referred to the bladder. So how do you know where does that come from? So the pain mapping is important to sort out the area, and the diagnostic testing to rule in or rule out certain problems. So for example, when a patient comes in with pain, and they would tell me their muscle spasm, they urinate, they hurt, or sometimes they done urinating, that's when they hurt. So when I do a bladder test, they could come in with a VAS score of 10 and they walk out with a VAS of 2. So we know that 80% of those pain came from the bladder, 20% of those come from the pelvis. And with this approach, many times after the mapping, oh, well, you get menstrual cramps. You must have endometriosis. So you do laparoscopy, you don't find anything. So it's how I approach the testing, and I just kind of sort it out with the algorithm now. The groin pain and the lower abdominal pain, if it stands out on its own, is one of the most difficult ones to deal with without sort of the nerve block. And if you do pudendal block, the ilioinguinal nerve or genitofemoral nerve pain would go away, let's say 70%. The patient woke up and still hurt. Then you know that area by itself is a generator. So then you can go ahead and numb that part. And if you numb that part a couple of times, the pain is corrected, then you know that is the biggest part of the problem. The rest of those could well be co-conspirator or a refer pain. So Dr. Zoland, I'd just like to see now the impinged hernia. I have seen it. There's a little hernia out in the pelvis and peritoneum. you think that doesn't matter, but sometimes that it has socket endometriosis there. So every little thing that counts, but I like to walk like a Christmas tree and up. The bottom of the tree is the pelvis, the bladder, the muscles, and the pudendal nerve. As you walk up, if you have short out some of the tree lights, the flickering up and down, it's like this nervous transmission goes up and down. So as you go up, you can kind of narrow down the branches. In the pelvis, there's a lot more branches. But once you go up to the lumbar, the ilioinguinal or genitofemoral, there's only a few branches there. So it's a lot easier to attack. I hope I answered the question. But
Mark, what's the deal with these non-bulging hernias? Because this is like a big problem that we have. You just mentioned about the special protocols that you have with your hernias, hernia diagnostic testing. And, what happens is that you got these MRIs where the radiologists call them normal, but, it indeed, and let's just mention that Mark he specializes in sports medicine. So he sees a lot of also athletes who come with this. Athletes call it different. They call it pubalgia. In the world of athletics, growing pain is called pubalgia, right? It's a very well-known thing. It's a very common problem. Do you want to expand on this, like the non-bulging hernia? What is the deal with that?
Sure. I want to jump back for one point. We've all been talking about nerve blocks, and I think it's really important for the patients out there to understand that if somebody does a nerve block and nothing happens, it means that the nerve block missed the mark. Something should happen with the nerve block. It may not mean that your pain goes away, but there should be an area of numbness that occurs if you're getting the nerve that you're going after. So oftentimes you'll get a negative result from the nerve block and yet you'll get numbness. So the point will be that, let's say you're getting the ilioinguinal nerve and you're looking for some numbness on the lower abdomen in the groin, and you get that numbness and yet the pain still exists, well, then you know that the ilioinguinal nerve is not the issue. But if you do the ilioinguinal nerve block and there's no numbness whatsoever, that doesn't mean anything. That's not telling you anything because the block has missed the mark. And this is what Dr. Mosbrucker referenced before. But I think this is a really important point because I think a lot of times if we send somebody to pain management, or you as a patient have been sent to pain management, or somebody trying to do a diagnostic block, and your pain doesn't go away, but nothing else happens either, nobody says to you, oh, we missed the mark. All somebody walks away thinking is, well, I already did the ilioinguinal nerve block and that didn't work, so that's not the problem. But unless you had numbness, and this is the key point, your nerve block doesn't mean anything. So that's the first point I want to make. The second is, so there's something called pubalgia. I'll get into that in a second, and I'll try and be really brief here. But hernias are often missed on radiology testing. It doesn't mean they're not in the study. It doesn't mean that you cannot find the hernia on the study, but the radiologist oftentimes will not call a hernia what to some of us is most definitely a hernia. And this is a definitional problem, and it's a big problem because the radiologist is taught from early on that a hernia has to be an organ, or it has to be a sac, or it has to be something from the intra-abdominal cavity coming outward. However, most hernias are fatty tissue. So if a radiologist doesn't call a fatty tissue hernia a hernia, and they say something on the bottom of the impression saying no inguinal hernia is seen or no femoral hernia is seen, and yet there's some fatty tissue going into the canal, this is indeed, from a definitional perspective, from a surgeon's point of view, still a hernia. And the reason why this is really important is that it doesn't matter what's going through the opening, it just matters that the opening exists. And the reason why this is important is because anything going through the opening can impinge upon the nerve and therefore cause a pain syndrome. So it's incumbent upon us, all of us as specialists in groin pain and pelvic pain, to be able to read our own imaging. Because one of my colleagues out in California, Shireen Tovai, did a study with her partners, and this was a study that we've known for a long time, 60 to 65% of the time, radiologists do not call hernias when they are indeed hernias. And they're indeed hernias when we go in and we operate and we see them. So we prove that these indeed are hernias. So if you have a study and you've read about hernias and you go into the study thinking, this sounds exactly like a hernia from everything I read, I'm sure I have a hernia, and the study comes out negative for a hernia, it means that maybe the radiologist hasn't read what you actually have. So it's very important to get your study to somebody to take a look at it who knows exactly what they're looking for. And this is what we call an occult hernia, or a hernia where there may not be a bulge, but indeed the hernia exists. And the reason why there may not be a bulge is it may be a small inguinal hernia, which is only fatty tissue. It may be a femoral hernia that's going down into the leg, or it may be an obturator hernia. So all of these hernias can exist. All of these hernias can certainly cause pain. And a lot of people walk around with a diagnosis that they do not indeed have a hernia, and yet they really do. So it's just it's an important point to make here. I just think this is critical. Finally, the pubalgia conversation is all the attachments in the lower pelvis go to an anchor point, and the anchor point is on the pubic bone. So everything essentially comes towards the center of the body at the pubis. And that's the rectus muscle coming down, the adductor coming up, the inguinal ligament going across. All these structures come together at this central anchor point. And that anchor point can come off the bone a little bit. And that's why it's called an athletic hernia or a sports hernia. At the end of the day, it's a tearing of the structure that oftentimes will get better on its own with some rest and some physical therapy. But if it doesn't, then you have to start considering that there's a chronic injury that's not going to get better without a surgical maneuver. And that's called a sports hernia or athletic pubalgia. They're terrible names, but at the end of the day, it's about a separation of the structure called the aponeurotic plate from the periosteum of the pubic bone. So I don't know if I'm confusing things or not, but that's sort of the broad strokes of this.
Mark, that was absolutely great. And I loved I think it was very, very important what you just mentioned about the not failed nerve blocks. It's not a failure. I mean, nerve blocks are hard. It's hard to get nerves. Sometimes you don't hit them. But if you don't hit them, you got to, make sure the patient knows that no nerve was hit. I got to change topic. We're going a little long. Dr. Mosbrucker, do ovaries hurt? Does ovulation hurt? And why? What's the deal with that? Why? What is ovulatory pain? What is ovarian pain? And do we know why that happens?
Well, ovaries absolutely can hurt. A lot of women will feel their ovulation. There's an old-fashioned term called Mittelschmerz, which means middle pain in German. Since my name is Mosbrucker, I know what that means. And ovulation typically will feel like some people will feel it as a pressure, other people will feel it as a pulling pain, other people will feel like literally a pop. Typically it lasts 12 hours or less and is not terribly painful. But as we know, pain is not necessarily completely related to the physical activity that is stimulating the pain receptors. It's also related to one's perception of pain and the degree of central sensitivity that an individual has. So women who have, for example, fibromyalgia, which to me is not really a disease, but it is much more of a issue of central sensitization, that they will feel their ovulation much more strongly, and they will perceive it as more painful than somebody who does not have central sensitization, who will just say, oh yeah, I feel it. Moving on from there, women who have endometriomas tend to have the most painful type of endometriosis. And especially as endometriomas get bigger than about 3 or 4 centimeters, they get up 6, 7, 8 centimeters and they become exquisitely painful. even to people who have relatively downregulated pain sensing systems. So yeah, absolutely, ovaries can cause pain. When ovaries are adherent to the sidewall, so say you have, say somebody has endometriosis underneath the ovary, and then it causes the ovary to stick or adhere to the sidewall, then when, even if there is no endometrioma, when you ovulate, then that is going to cause a pressure or a pulling sensation frequently on the endometriosis on the sidewall. And then that can become much more painful than a normal ovulation. I just want to go back, if I could, to something that both you and Dr. Chung were talking about, which is the different types of sensation that people will feel. And some of my patients, I talk to them and I'm like, where does it hurt? And they're just like, it hurts everywhere. Well, what does it feel like? It just hurts. And I'm like, thank you very much for that beautiful description. It really helps me figure out what your pain is from. Other patients will come in and say, you know, when from ovulation until the start of my period, I feel stabbing pain on my left side. It typically comes and goes. I feel cramping pain with my period. I feel burning pain over here. I feel, you know, and they're very specific with their descriptions. And that is so helpful for me to figure out exactly what is going on. So for the patients who are listening, I would really encourage you, before you go see a doctor for pelvic pain, try to sort out what exactly it is that you're feeling. When do you feel those things? Is it before your period, during your period? When did this start? Did it start gradually? Did it start all of a sudden? Did you start having groin pain on the right after you broke your ankle on your left? I mean, all of these things are very important in trying to figure out what's going on and what's the underlying root cause of the pain. Because as all of our panelists were alluding to, there can be pain upon pain upon pain. And I call it the onion of pain. And you can peel off layer after layer, but until you get to the root cause of what is causing the basis of the pain, it's going to be tough to fix it all. So,
thank you, Cindy. I'd like to add a little point about ovulation pain that many do not probably know about. That when they did the early studies on ovulatory pain, they discovered that most ovulatory, I want to leave that little logo in the back. I'll do it like that. Okay. Most people who feel what we call ovulatory pain are actually not feeling the actual ovulation. But actual ovulatory pain, usually it comes right before ovulation, usually 12 hours before ovulation. And it's thought to be caused by a surge, by the LH surge that induces increased contractility of ovarian perifollicular smooth muscle. And this is an effect which is partially mediated by prostaglandin F2 alpha. And which is very interesting because, and I didn't know this, but and you may not know this, but the actual pressure in the follicle about before ovulation doesn't happen by pressure. It's not like a burst. It's really more like a physiological event that doesn't involve increased pressure. It's more of that muscle contractility, look at this, that happens due to prostaglandin elevation, which kind of, if you think about it, some of the mechanisms, some of the pain mechanisms related to endometriosis are related to what we call sort of like those, there's a term for it, that, the silent nociceptors, which is it's a prostaglandin mediated phenomenon. Okay, which makes sense. That in endometriosis, you got the inflammation, you have increased prostaglandin, hence the greater sensation to ovulation, and that's really how that plays itself out. But I think it was an interesting information that ovulatory pain doesn't happen at the moment of ovulation. It happens with the LH surge. Dr. Chung, any comment about the, why, if once somebody feels something, they can't forget it, right? So once somebody feels ovulatory pain, then they'll always feel it. Is there like a memory mechanism? What's going on with that? We don't have a lot of time, so let's try to wrap it up very quickly. Like you only have a couple of minutes to.
Okay, well, I tried to make it simple. So ovulatory pain. So when women have two ovaries, so is the pain only on one side or both sides? And why is it always hurt more on the one side, or the other side never bothered them? So that gives you a clue. Do they have memory on that? Yeah, because they hurt. And anytime it's the right side that hurts, so the right side hurts more. So again, during the pain mapping, now, can I produce the ovulatory pain? Well, if I hit the pain trigger spot, right? So if I touch the pelvic certain spot and I say, is this your ovulatory pain? A patient, yes, it's exactly felt the same. So I know that I hit that spot. And most of the time, that spot is right at the ischial spine. So of course that there are some other area, but how do you know it's endometriosis, endometrioma? You order like $1,000 MRI or CT scan, ultrasound, you still have to do surgery. So I tend to desensitize the whole pelvis first. So yes, they do have memory. Pain is like they always remember, even though the pain gets better, with time it'll come back because we are who we are. We irritates them for the previous X number of years in their life. So the pain will come back. But at least that if you know what causes it, they may be able to alleviate some of the symptoms, feel them they are under control. And most of those, believe it, it's the pelvic neuralgia, the pudendal nerve, unilateral, one side is worse than the other. You can have a big ovary. I've done that. A patient with ovaries of 10 centimeters on the right side. So painful. Come to the office. I put some anesthetic in the bladder. The pain disappeared completely. Oh, it's not hurting now. So why the heck that the bladder hurts and you get a big ovary? So the big ovary had nothing to do with the pain. It's just that there are some neural crosstalk that make it happen. So don't forget. I hope I can make it more complicated.
Cindy, the patient comes, you've done very quick, done surgery, all the endometriosis is gone, few periods come back, ovulatory pain. What are we going to do about that? It's a common problem, the ovulatory pain.
Well, probably, as long as they're not actively trying to conceive, I will generally put them on progesterone and see if that helps to try to stop their ovulation.
Yeah, I would agree.
And see if that helps. And it will do two things. It will downregulate whatever endometrium or endometriosis is present. So if they still have their uterus, it will decrease the prostaglandin production from the uterus and the endometrium. It will also suppress ovulation, so there won't be any pulling on whatever adhesions there may be around the ovary, if there are any. And generally, I would say probably 90% of the time that works. I would also say that the biggest reason that I have to reoperate on patients is for ovarian problems, either adhesions or recurrent endometriomas, especially in women who had endometriomas to begin with.
Yeah. Now, so much to talk about, but we're approaching the end of our conversation. So I would like, first of all, to send all our love to Sally Sorrell, who was not here with us tonight. And we know that Sally is the force, the greatest force behind the Endometriosis Summit, but also I would say a major force in endometriosis education and advocacy today in the United States, if not in the world. So we miss you, Sally, and we love you. We also like to mention about the Endometriosis Summit, and we're looking forward to it. www.theendometriosissummit.com. First of all, I'd like to thank Dr. Mosbrucker, Cindy. We know your website is pacificendometriosis.com. I know we're looking forward not to see you in person, unfortunately, but to virtually see you at the summit. And any comments or anything you'd like to say to our listeners tonight?
Well, just, thank you for all of your efforts at advocacy. We all know that ACOG is a problem. The training of gynecologists and to a lesser extent other surgeons, but especially gynecologists, should be better trained at endometriosis. And the only way that that's going to happen is for you guys, the patients, the mothers of patients, the spouses of patients, to really speak up and be heard. And as a surgeon who takes care of women with endo, it really bothers me when I see how you guys are treated by gynecologists who are not in the know with respect to endo. And so, we stand with you, and we encourage you to make your voice heard. And I just want to say how much I appreciate the advocacy and all the work that you guys do.
Thank you very much. That was wonderful. Dr. Chung, anything you want to share? You've been here, we're going to hear, of course, at the summit, we're going to hear in great detail, and he alluded to it, his ilioinguinal pain protocol that is amazing, and he will be talking about it at the summit. But anything you want to share with our listeners tonight, Dr. Chung, as a goodbye?
Pelvic pain is just so broad. Usually it's not just one reason, one trigger. Usually it's multiple. Let's say you have bladder, bowel, muscle, nerve, lower back. So when they hurt you, it could be A, B, C, or A, B, D, or B and C and D and E. It depends on how you can sort out the triggers. And go back to the ovarian pain, ovulation. I typically nail down that pain first before I even do surgery on it. So I know that the pain, it could be a referral pain. And so if that's gone even before surgery, I know that it's nothing to do with my surgery anymore. So that's all I could share with you. But again, the pelvic pain, 85% of all the pelvic pain came from the bladder or component of the bladder. And actually the pudendal nerve, which is the pelvic nerve that accountable for probably close to 85% of those, it may not be the cause of it, but certainly is a referral pain neural crosstalk. And so
Dr. Chung, how do people find you? How do our listeners find you? They go to the Mercy website, right?
I can go to the Mercy website. If you type my name on the internet, you'll find me. But there are 7 Dr. Maurice Chung in the country. But I think it probably
so just say the good-looking one, and you're gonna find them. Okay, just say the good-looking one. Dr. Zoland, thank you so much. I think that, I'm very happy that Dr. Zoland exists because he has solved a lot of problems, a lot of mysteries for us, where hernias or less known sources of pain were present, and nobody could figure it out, and he did. Anything to share with us? Of course, he will be present at the Endometriosis Summit. Get your tickets today, listeners. www.theendometriosissummit.com. Mark, final words?
No, just thank you, really. Dr. Vidali and certainly Sally, you guys are the prime movers for this. I can't thank you enough. I think patients really get so much out of it. And, the only thing I'll say to patients is, if you have a doc that you just don't feel is getting what you're saying, they're not, and I think it's time to move on to the next one. You have to find the docs that really are trying very hard to fix these issues with you. So just really, and it's sad to say, but you need to be your own advocates, and you need to, the internet helps, you need to do the research and just keep plugging at it until you find somebody that's really listening to your symptoms. And listen, we don't have all the answers. We absolutely don't, but you know, you just want somebody that's really going to try to figure it out with you.
Well, thank you to all the panelists. We are one voice together for change. And at the Endometriosis Summit, we at least try to involve everybody and as many people as we can, new ideas. And this is what you're going to see at the next summit. I'm honored to have participated in this evening with this amazing